Welcome to the next edition of Doc Talk at Sukino. Sukino is involved in post-operative care, recuperative, rehabilitative, and palliative care. This time we have renowned Dr. Sachin Gr, a senior neurosurgeon with over 13 years of experience in the field of neurosurgeon, presently as a senior consultant at Apollo Hospitals, Banarghatta Road and Sarjapur Road. Welcome to Doc Talk. Dr.
Thank you.
Sachin.
Thank you very much, Dr. Harish.
Dr. Sachin specializes in brain tumors, skull-based surgery, spine, and in pediatric neurosurgery. Today, we'll be focusing and talking about skull-based surgeries, brain tumors, and spine, and why rehabilitation is important following these procedures. Dr. Sachin, I'd like to start. What inspired you to choose neurosurgery as a profession?
Yeah, so I was in general surgery. My first posting was neurosurgery when I joined general surgery in 2008.
Great.
So the person who I worked under, a neurosurgeon, I'll not take his name. He was a wonderful neurosurgeon, and his work inspired me a lot. So he was so dynamic. He used to come on time. He used to operate. We used to see the results out of the patients, and I was very happy by the way the patients came out and by the way he treated. So all these things inspired me to become a neurosurgeon. Basically, neurosurgery is a dynamic branch. It is a vibrant branch, and you need to be at the tip of your toes to take a call anytime, anywhere. And this inspired me to take neurosurgery. And of course, brain is such an intricate organ. You feel fascinated to see how the brain behaves, how it is interconnected to the rest of the body, and how a small change in the brain can lead to so many malfunctions in the body. So it's very wonderful to study all this. All these things made me to be a neurosurgeon, frankly speaking.
Amazing. It's great to see a 1.5 kilo organ control the whole body of 80 to 100 kilos.
Yes.
Interesting to see that there have been important people who have inspired you to take this particular field.
True.
Great. Neurosurgery is often perceived as a high pressure field where precision, timing, and everything matters. How do you approach to this emotionally, professionally, and physically?
Yeah, it's a very the question which is asked by most of the people who are fascinated by this field. I would put all this. I would thank my institute from where I trained, the neurosurgery, the PGI Chandigarh. My teachers from PGI Chandigarh are my gurus who actually inspired me to be what I am today. So more than neurosurgery, we have been trained to be more disciplined, more focused, more hardworking. That's how the neurosurgery comes into its path. It takes its path. Of course, we keep doing many other things to keep our stress off from the field. The most important thing is, of course, we have to learn we have to like our field, neurosurgery. We have to be very passionate about it. That's what I am. I'm passionate about the work I do. I enjoy operating. Even if we operate for 4 hours, 5 hours, 10 hours at a stretch, we don't get stressed because we enjoy doing it.
Right.
So that is the way we get distressed ourselves. Surgery is the one thing for me, which keeps me inspired and going on and on. We do a lot of other things, especially with the family. When I spend time with my kid, with my wife, with my family, with my parents, so we get offbeat from neurosurgery. We get relieved.
Right.
I listen to a lot of music. I do bird photography and some other hobbies also. I love traveling. I take my car and go on a long drive. So
Wonderful.
these things keep me focused on my field. That's what I can say.
Great. I also have understood like you have a special training from Osaka, Japan, and as well as Seoul, Korea. Would you like to elaborate on your trainings and expertise over there?
Yeah, so I was trained in skull-based surgeries in Osaka. I was trained under Professor Kenji Ohata. He's a big name in skull-based.
Right.
So I spent almost 6 months there in assisting cases and observing what they used to do, the complex cases. It has definitely helped me to treat my patients here. And we have given good outcomes by the training what we have achieved there and applied it to our patients here. It is definitely an add-on. And a lot of neurosurgeons, young neurosurgeons who are getting trained should go for fellowships and get trained in the field or in the subspecialty branch they like. Now it is more of a concept of subspecialty in neurosurgery. It's not just the general neurosurgery practice what we follow. We need to subspecialize ourselves. That is going to be the future in the next 10, 20 years. And in Seoul, we have done a training on endoscopic spine. That is an emerging thing which we do for spine surgeries. It's a minimally invasive surgery using endoscopes with small incisions. We try to operate and give outcomes.
Great. Amazing. Now, you're a neurosurgeon by training. Would you like to share your perspective, how you approach the brain surgeries compared to spinal surgery?
Yeah, so neurosurgeon means as a common man, people have to understand that it has got two components. One is, of course, the brain and its continuation, that is the spine. So neurosurgeon is both a brain surgeon and a spine surgeon. So a lot of people have this confusion. Neurosurgeon only operates on brain. Spine is by orthopedic spine surgeon.
Correct.
Yeah, so this is a misconception. So neurosurgeon is also operating on the spine. So in fact, most of our volume is spine. Around 60% of our volume is from the spine. So we do deal with the spine and spine related issues, including tumors in the spine and the spinal degenerative disorders, which includes listhesis, that is abnormal spinal deformity. It can be a scoliotic deformity, it can be a step deformity. So we do fusion surgeries, what is known as putting instrumentation and screws into the spine. So these kind of basic surgeries are also done. We do simple discectomies. We use microscopes. Some neurosurgeons are trained to use microscope. That is a machine in which it needs a lot of hand-eye coordination. So with the help of microscope, it helps us to give good results because there is a magnification, excellent magnification, there is an illumination. So all the nerves and the nerve-related structures, neural structures, neurovascular bundles are excellently seen through the microscope. So the outcomes are excellent. The safety for the patients are excellent. So neurosurgeons are trained to do the surgeries with the microscope. So we apply that for the spine surgeries and for the brain surgeries. So both are different, but both are operated by neurosurgeons. Of course, the ortho spine surgeons who are trained in spine surgery fellowships, they are also operate on spine. But the tumors in spine are taken care by neurosurgeons.
Right. Thanks for clarifying this. It's very important for people to understand when to seek the right help and the right expertise. Usually the symptoms come first, followed by the signs. What are the serious signs that you would like to tell to our viewers so that they can seek help at the right time?
Correct.
What are the serious signs of an underlying neurological disease?
Yes. So one thing I want to say, if it is anything related to the brain, the most common symptom everyone would have faced by now is headaches. So it doesn't mean that if you have an headache, you will have an underlying disease or an underlying disorder or a tumor or something. It's not always true. Most of the time, 90% or even 95% of the times, a headache is just a simple symptom which can be ignored or which can be dealt by taking an over-the-counter drug or just show to your local physician and they can take care of your headaches. When this headache is alarming is if the severity in this headache increases over a period of time or the character in the headache changes,
Right.
or if it is associated with other symptoms like the patients can have visual disturbances, they can have a seizure or a fit, they can have other symptoms like vomiting, they can have weakness or stroke kind of symptoms like the patient can suddenly develop a weakness or difficulty in moving his hand or leg. So these kind of symptoms will raise an alarming sign in which we have to seek a urgent neurological or a neurosurgical advice. Sometimes if there is extreme consequence of the headaches or these symptoms where the patient can land up in a coma or a semi-coma kind of stage, that is they go into a stroke kind of symptom.
Right.
So then they have to be rushed into an emergency to a nearest hospital.
Correct.
That's where they will get evaluated with various tests and then they will be decided upon what needs to be done next. Yes.
Right. One of the fears a patient faces following a diagnosis is the fear of surgery. What are the myths associated with neurosurgery and how do you help your patients by addressing them promptly?
Right. So the neurosurgery is changed a lot over the last 3 decades. The microscope has changed the era of neurosurgery. Before the era of microscope, the surgeons used to operate with naked eyes and the results were not that great. Of course, we appreciate those surgeons. They are brave surgeons, and because of them, there is a transformation. There's one Dr. Yasargil who is called as the father of microneurosurgery, who transformed the surgeries, the way neurosurgeons operate on the brain and spine. And now, because of people like him, we are at ease and we are able to give excellent results to our patients.
Right.
So, with this technology, over the last few decades, there has come the microscope, there has come the navigation system, the neuro navigation. This is nothing like but a GPS kind of system, your Google Maps. So, the navigation helps us to navigate intraoperatively for precision and guides us to operate on a very specific location in the brain so that the results are excellent and the deficits or the sequelae post-operatively are very less, minimal. There is also for spine surgeries what we known as recently we have a robot, the spine robot, which helps or guides us to put the screws exactly in place. We have the OARM technology. It is an intraoperative CT scan, which helps us to navigate and operate on the spine. So a lot of newer equipments, expensive equipments have come, which are available in very higher centers, and this will help as transform the neurosurgical practice. And this helps us to give good results and excellent outcomes for the patients.
Great, Dr. Sachin. You have explained eloquently like how the field has evolved with advancing technology, with a lot of state-of-art equipments that are used. Coming back to the spine to address it, like what are the common symptoms and signs you see in young adults and working professionals, and when should they seek your expertise or your consultation?
Yeah. So nowadays, especially the IT professionals and the people who do a lot of desk job, we see a lot of spine problems. And most of them come with the lower back pain or the neck pain or mid back pain, headaches. So these are the symptoms they come with.
Right.
Most of it are related to an abnormal posture. So they sit with the back. Most of them they sit. They're not focusing on their back. The way they sit. So abnormal postures will result in muscle spasms and will result in chronic back pain. And the way they sit, they're always tech savvy. They're always using their laptops or phones. They're not focusing on the position of the neck. So because of this, they keep getting the neck pain. And people keep riding the bikes or drive for long distances. They can also have these issues because of abnormal posture and position. So a lot of patients who come with back pain and the neck pain, most of them will be related to the spasm of the muscles. So they don't work out, they don't do regular exercises, and they add on weight. Most people add on weight. So all these things, sedentary lifestyle, stressful lifestyle, and habits like smoking, alcohol, all these factors will add on to the problems of spine issues. So these things can be dealt, mainly most of the things can be dealt with just lifestyle modifications, which is very essential for younger generation. That is the advice I would like to give.
Now, a lot of people seem to have back pain. What would you call a red flag during the process when a person is undergoing back pain? When is it that they should consult you? And what are the signs, or how would you like to evaluate them to see what are the major issues?
Correct. So all of us would have had back pains in our lifetime once in a while, right? But most of them doesn't need to be addressed like I mentioned in the previous statement. When is the back pain very significant, very important, or it needs to be attended by a surgeon or a physician is the red flags signs are there can be a radiating pain to the leg. That means the pain in the back will also spread to the leg, either one leg or both the legs. They can have pain which spreads to the leg when they're walking for short distance. This is called neurogenic claudication. They can have numbness or heaviness in the legs when sitting or when walking. They can have urinary disturbances, urinary incontinences, bowel issues because of the back pains. So these are the signs which will prompt us to go to visit a neurosurgeon or a neurologist or a spine surgeon. They can have weakness in the leg. There can be a sudden deficit in the leg or the foot. They are not able to negotiate their foot into the slippers or the shoes. And there can be stiffness in the hands, stiffness in the legs. So all these are the symptoms which will allow us to meet a surgeon.
Coming to brain tumors, what are all the symptoms people usually experience, and how do they know that when they should reach out to a specialist and should not be just ignoring it or taking any placebo or any symptomatic treatment.
Correct. So usually the brain-related issues are mainly because of the tumors. The tumors can be both benign tumors and cancerous tumors. There can be issues in the brain which are not related to tumors, like there can be issues with the blood vessels in the brain. These are called cerebrovascular disorders. There can be some connective tissue disorders. There can be skull-based lesions. Again, that comes under tumor. There can be infections in the brain. So a lot of things can affect the brain.
Correct.
Because of these things, they can have various symptoms. Like I mentioned previously also, headache is one of the most common symptoms. Apart from this headache, if there is any acute stroke or bleeding within the brain, they can have a very severe form of headache. That is called thunderclap headache. They would have never experienced such an headache in their entire lifetime till then. So this is a kind of headache which is very important and should not be ignored.
Right.
Other symptoms like seizure. Seizure is a fit. Basically, patient will have an involuntary movement of either the hand, and then it will get generalized and the patient can go into an unconscious status. There can be frothing in the mouth, uprolling of the eyes. They can urinate or micturate within the dress, soiling. So these things can happen. That is when it indicates that it is a fit or a seizure.
Right.
When this happens it can happen to anyone, anytime. So if you come across a patient who is experiencing that, make sure he doesn't bite his tongue, turn him to one side so that anything comes out like a vomit or anything, he shouldn't aspirate it. It shouldn't go into his lungs. And turn him to one side and make sure it doesn't bite his tongue. So this way we can avoid catastrophic things happening and we can save his life, and immediately rush him to the nearest hospital where there is a facility for an emergency. Other symptoms like they can become unconscious, they can have weakness of one side of the body, they can have fever, there can be weight loss, there can be difficulty in eating, so many things unrelated to the brain. Patients can present with these symptoms. Anything unusual, please see a doctor.
Exactly.
Yeah.
So what Dr. Sachin tries to say is that despite the etiology being different, the symptoms could be common and that can be very confusing. So it's very important to seek help. Dr. Sachin, you are also talking about tumors that could be benign or cancerous. How would you differentiate them, and how do you counsel a patient who's frightened following the diagnosis of a tumor?
Correct. So brain tumors can be both benign, that is non-cancerous. That means it is just a kind of swelling which doesn't have an aggressiveness to reform again or spread to other parts of the body. These are called benign tumors, or it can be a malignant tumors or cancerous tumors. Cancerous tumors are the ones which usually tend to reform or recur again, and they can spread elsewhere in the body, and they are very aggressive. And the lifespan usually in grade 4 tumors, cancerous tumors, are very short. And these cancerous tumors are the ones which needs further treatment after surgery in the form of either radiation or chemotherapy, which we involve usually the medical oncologist, and they will do this further treatment. Right. So the benign tumors are the most common kinds of tumors. They can occur anywhere in the brain. I'll take this brain model to explain. So this is how the brain looks usually, roughly. So we have got two parts of the brain, briefly to tell. That is, one is the supratentorial part. The other is the infratentorial part. The supratentorial part means the bigger part is above the tent. That is a layer of dura which separates the upper part of the brain, which is called the cerebrum, and the lower part, the cerebellum. The upper part mainly is involved in the functions of movement of the limbs. It is involved in the speech. It is involved in cognition. It is involved in memory, and it is involved in many other functions. Right? And the lower part, that is the cerebellum, it is involved mainly in the hand-eye coordination. It is involved in balance of the patient. Yeah. And there is one more vital part, the white part, that is called the brainstem. And this brainstem is supposed to transmit most of the functions of the upper part of the brain and the cerebellum into the rest of the body.
Right.
It is also responsible to control our heart rate, our respiration, and other vital functions.
Right.
That is how the brain is divided into these many parts. And the tumors can occur anywhere in the brain, and based on the location of the tumor, the symptoms do occur. So the benign tumors are usually treatable once they are diagnosed with either MRI or CT scan. They are subjected for surgical excision. So with the help of this microscope and navigation, we try to completely excise the tumor based on the location. And once they are completely removed by surgery, it is mostly cured for life. They will get back to their routine life. Whereas the cancerous tumors, as I mentioned you, once the surgery is done, they would probably need further treatment in the form of radiation treatment or medications in the form of chemotherapy.
So you do great surgeries that involve the brain and spine. Some of these surgeries are major surgeries. You need to have a care plan post procedure. This is where early rehabilitation has its role to have more optimized or better outcomes. What would you recommend to your patients following the major brain or spinal surgeries? How do you recommend the rehabilitation? How do you emphasize the importance of adhering to the rehabilitations?
Yeah. Nowadays, because of these advances in the technology and the outcomes are excellent, the hospital stay is reduced significantly.
Right.
So we usually, the patients need to stay in the hospital for a couple of days, maybe 3 or 4 days or a maximum up to a week or so.
Correct.
And then comes the need for transition care.
Right.
10 years before, there was no concept of transition care, rehabilitation care like you mentioned.
Correct.
So it was very difficult for us to explain to the relatives and for the patients, relatives and the patients to understand how it needs to proceed. And a lot of things and issues used to happen at care because of the care at home. They used to usually hire a nurse at home, or they used to hire equipments like a bed or something like that. Many suction tube if the patient is tracheostomized. So all those things they used to do at home. It used to be a lot of cumbersome things. Educated patients, of course, try to manage most of the things. But in the others, there used to be a devastating situation also. Most of them used to come back with complications like a deep vein thrombosis in the legs, or the bed sore, or an infection, chest infection. So all those things do happen in the neurosurgical patients because most of them are bedridden for long time, especially the head injury patients who needs care, and the big tumors which have been operated who have deficits preoperatively, they tend to take time for them to recover, usually 4 to 6 weeks. So this is the time when they need this transition care, and that will definitely help them.
So essentially, when the acute care in the hospitals is done, that's when the role of recuperative and rehabilitative care comes in. This involves connecting with the primary doctor, understanding the patients, understanding the unique features, and to chart out a unique plan for the further rehabilitation. This is best done in a transitional care center, which is dedicated doctors, nurses, rehabilitation specialists, speech and swallow pathology specialists, occupational therapists, respiratory therapists, clinical psychologists, dietitians, and other specialized nurses who are focusing on the transitional care, a care that cannot be provided at home. Sukino emphasizes on this transitional care aspect as a continuum. We are in touch with the primary doctor to ensure the continuity of care during this journey. Now, after a major brain or spine surgery, the patients and their relatives are clueless. They probably think that this is the end of the treatment. But then a lot of work needs to be done where a proper recuperative and rehabilitative care ensures a more optimized outcome and a proper rehabilitation back to the society. Could you give an example or explain how this rehabilitative process, if started early, can result in better outcomes?
Yeah, so I will quote this with the patient example which we have treated recently.
Right.
So this was one young 40-year-old female who had presented with seizure that is fit on one side of the body. She was having a tumor on the motor cortex. I'll just show with the help of this brain model. So motor cortex is the area of the brain in the frontal lobe which controls the movement of the hand and the leg on the opposite side. Okay. So the tumor was sitting bang on that. So this is called the eloquent area of the brain. Eloquent means one of the important areas of the brain. And this seizure, which she presented with, she was already operated on a similar tumor few years back, and she had lost follow-up. And that time also it was a benign or a non-cancerous tumor. Since she had lost follow-up and because of the seizure she was presented, after evaluation with an MRI, we came to know that there was a recurrence of the tumor at the same place.
Right.
So in recurrences, the surgery is a bit challenging compared to a virgin area, the virgin surgery. That is because of the adhesions. The tumor is stuck to the brain and stuck to the surrounding structures because of the previous surgery. So it makes the surgery a bit more difficult compared to the primary or the fresh surgery. But still, with the help of the navigation systems, with the help of the technology, we were able to completely excise or remove the tumor. This time also it came as a grade 2 tumor, which was a non-cancerous tumor. Later on, she was subjected to the radiation or the current treatment also because it was a recurrent tumor. Unfortunately, since the tumor was sitting on the eloquent area, that is the motor cortex, and we took utmost care not to touch the brain, despite that, she ended up having a plegia on the opposite side, post-operative.
Correct.
Plegia means there is a complete loss of power of the leg and the hand immediately post-operative.
Right.
So we did scans, we found out the scan was wonderful, the complete tumor has been excised, there is no bleeding in the tumor bed area. Sometimes that can happen, and because of that they can have this weakness. Nothing that sort of, everything was fine. So the brain is a very sensitive organ, right? I said you. So because of even a little bit of handling, they can have this complete weakness. Patient is devastated, the relatives are devastated. The only thing they ask is, sir, surgery munche ella sari ittu, surgery ಆದ್ಮೇಲೆ ಕೈ ಇಲ್ಲ ಕಾಲು ಇಲ್ಲ ಈ ತರ ಆಯ್ತು. That's what they say. So we have to assure them, we have to make sure that we talk to them regularly, compassionately and emotionally. So they will understand. Patients do understand because they believed you, they trusted you, they came for you, and you've done the surgery, you have shown them that the tumor is removed. There was no other choice, right? The patient had these seizures and we had to do the surgery. So after surgery, when the patient had hemiplegia, so the next step was to shift them to the rehabilitation center. This is where the role of rehabilitation comes into picture. And that is what, and we shifted her to the rehabilitation center. She stayed for a couple of weeks. After 2 or 3 weeks, slowly her leg started moving. She started flexing her leg. She started developing sensation in the leg. Then she started moving one finger, 2 fingers, then all the fingers. And over the next 3 months, she came to my OPD walking.
Right.
There was a big smile on the face of her and her husband, and they were very thankful.
Right.
Very thankful. So this is one of the example where rehabilitation makes a big difference for the patient.
Right.
And why this happens? There is a concept called as neuroplasticity.
Right.
The whole world is working on neuroplasticity in neurosciences in today's world. A lot of new things are happening in neuroplasticity. Just to make people understand what is neuroplasticity. For example, in an office, there are 10 people working, and suddenly one person takes off. The work still goes on. The other 9 will do the work of one person, right? So this is neuroplasticity. Basically, the surrounding nerves take over the function of the damaged nerve. There are millions of nerves in the brain which are involved in one particular work. So when the surrounding nerves take over the function, whatever the lost neurological deficit has happened, that will recover slowly over a period of time.
Correct.
That is the concept of neuroplasticity.
Right.
And the neuroplasticity is quite excellent in children. If you have seen, if you must have seen, the children recover faster in any head injury. Children you see versus an adult or an old person with an head injury with the deficits. Right. The children do recover faster compared to the adults because the plasticity is excellent in children and not in the. I mean, it's good in adults, but it's excellent in the children. Like just for an example, a fresh worker, you can train them better than a senior worker, right?
Right.
Something like that.
Exactly. So it goes to show how rehabilitation, monitored care, a care plan in connection with the primary doctor, the surgeon, ensures the best of the outcome. This involves the team of doctors, nurses, physiotherapists, occupational therapists, dietitians who monitor the health of this patient over weeks and months to ensure that the hard work of the doctor is completed and brought to a logical step where the patient is back to his original functional self. What do you feel about the concept of very early mobilization following surgeries?
Please.
Yeah. I wanted to talk especially in the context of spine surgeries, where early mobilization would result in lesser complications. What has been your experience?
Yes. So, like you said, even the concept in spine surgery has changed now. So, before we used to put in long incisions, multiple hours of surgery, a lot of blood loss in the surgery, these things were there. Now it has transformed into what is known as minimally invasive spine surgery. And of course, the new concept is the endoscopic spine surgery. So, with this, the incisions tend to be smaller, there is lesser muscle dissection, and the lesser blood loss. So the outcomes are excellent. Post-operative pain is less. So we believe in early mobilization. Immediately the next day or within few hours of non-fusion surgeries, we tend to make the patient walk with the help of the physiotherapist.
Right.
Or in case of fusion surgeries, the next day with the help of belt and the physiotherapist, they make them walk.
Right.
So that is the concept of spine surgeries nowadays, early mobilization.
Right.
So early mobilization, it helps us prevent complications like deep vein thrombosis or DVTs in the legs, and the weaknesses tend to improve faster because of the plasticity. The more you make them walk, the spasticity or the contractures, all those things will be prevented.
Right.
The patient can go home early. So all these advantages are there. So early mobilization also gives a positive vibe for the patient. They feel that there is no surgery which has been done. So they have this positive atmosphere within themselves.
Right.
They start walking, they see the sunlight in the hospital, they feel better. It's a good vibe happiness.
How extensive or vast is neurological rehabilitation? The symptoms and persistent problems with respect to weakness, paralysis of half a side of the body, difficulty in speech, difficulty in walking, balance issues are among the commonest problems that the patient face. How do you chart a plan for a rehabilitation that is extensive but still comprehensive and hence in proper goal-oriented therapy?
Okay. So the neurorehabilitation is a concept which involves multidisciplinary team approach. It's not just a one-man show.
Right.
It's not just about the patient and a physiotherapist coming and doing some exercises, limb exercises, and going back. That is not what is neurorehabilitation.
Right.
If that is the thing, it can be done even at home or hospital for a couple of days and sent to home, right? So that is the reason why this concept of the neuro rehab centers have emerged and are emerging more and more common. Because the multidisciplinary team basically it involves treating the patient as a whole. It from starting from the motor skill development, the motor development or the motor rehabilitation, which involves the physiotherapist. It involves the occupational therapist.
Right.
Occupational therapist mainly deals with making the patient independent and trying him to get his routine work done on his own. So this is what the occupational therapist deals with. The speech therapist, especially when the speech areas are affected, so the patients can become aphasic or they are not able to speak completely, or even if they are able to speak, they are incomprehensible, or they are not able to understand what others are speaking. So many issues are involved in a speech. So speech therapist will try to address this part. There can be, the patients can be tracheostomized. So we need an ENT specialist on a routine basis to take care of that. There can be bed sores because of the bedridden status. So we need the general physician and the general physiotherapist and the neuro physiotherapist. So a lot of people are involved in a neuro rehab or a neuro rehabilitative care. So that's what makes it a comprehensive and complete care for the patient, so that the total outcome is focused upon. Nowadays, of course, in the neuro rehabilitation, there are some advances also which are coming up, like robotics and brain computer interface, which tries to focus on basically how the patient's thoughts are getting converted into the movements.
Right.
So there are many advances which are coming up, which will definitely be the future, maybe 5 years to 10 years down the line.
Right.
And which will help our patients. Yeah.
I'm sure there are a lot of avenues left to be
Correct.
explored. Now, coming to another aspect, what do you think is the role of nutrition and nursing care following neurosurgical intervention during the process of rehabilitation?
It's very important, especially this chronic patients, chronic bedridden patients are cachexic, because of lack of nutrition. Most of them are on the Riles tube feeds. So because of the Riles tube feeds, it's usually the liquid diet which has been given through the pipe through the nose, and they end up having deficits in protein intake. So there is a severe weight loss. There is no proper protein intake, and because there is lack of protein intake, the patients tend to lose more proteins because of the muscle mass is getting deteriorated, right? Muscle mass is getting wasted because of the bedridden status. There is no exercises. All this leads to chronic non-healing status, or whatever they are supposed to recover, it gets delayed.
Right.
So nutrition is very, very important. For chronic patients who are on Riles tube, we usually recommend what is known as PEG. PEG is a direct gastrostomy. We use a thick tube directly inserted into the stomach by an endoscopic procedure. It's a bedside procedure.
Right.
Through that, the intake can be increased. The number of, the amount of food given, the thick food can be increased. Therefore, the nutrition and the protein intake can be increased. So this will help us to gauge the outcome of the patient's status, which is improved. Nowadays, we also have beds which can weigh the patient. On the bed, we can weigh the patient. So on a day-to-day basis, we can know whether the patient is losing weight, losing protein, or is maintaining the weight. So that will also help us to increase the nutrition. And we have dietitians. Dietitians are excellent in making a decision on what feeds needs to be given to what patient based on their weight, their intake, their output. All those things can be measured, and it will definitely make a difference for the patient and their outcome. Yeah,
right. Good to know. Would you like to talk about the emotional and psychological aspects that you encounter with your patients and their relatives post-operative when they are undergoing rehabilitation? When not to lose hope, how do you provide it to them?
Yes. So we see a lot of emotional disturbances in the relatives of patients, especially who have had these issues suddenly. Like, for example, it can be a road traffic accident. A good day, everything is fine. A person is traveling to his office, he meets with an accident, and then is completely unconscious. And then we do surgery, then we shift him to the rehabilitation center. A wife is taking care with 2 kids. We realize that he's not what he was 2 days back, right? And he's completely unconscious. Then that is when they start realizing that life has changed suddenly. What was there yesterday is not there today. It is so devastating. Right. Financially, it is very devastating. Emotionally, he's alive, but he's not what he is. So they try to talk to him. He's not recognizing them. It goes on for long, very, very long days. And this thing keeps on hitting them emotionally, especially in road traffic accidents and strokes, acute strokes, where the patient comes with big bleeds and we do surgeries. And especially on the left side, it bleeds, in which their speech is affected. They're able to see their relatives. They're able to we can see tears from the patient's eyes, but they're not able to talk, or they're not able to reciprocate what they want to say. So all those things keep happening. So this is when the emotional turmoil hits at its peak, and it definitely it's a very difficult situation. Most of the times we need the involvement of psychologists or a psychiatrist to stabilize these things. And over the period of time, when we, with empathy and sympathy, talk to them, gives time to the relatives, they definitely get consoled and they will understand. We all have to understand the reality of life. There is something beyond science, beyond neurosurgery, that is God. So these things will take time. It has to be addressed in a proper sympathetic way.
Right. Understand. How can families seek support during this difficult time? We at Sukino provide psychological counseling, and at times when we feel that something is wrong, we would like to get the patients back in touch with the primary doctors, explore the role of certain interventions, including a clinical psychologist or other counseling measures. Have you found this kind of counseling useful in the path to recovery?
Definitely. As I mentioned you, there will be a financial burden. There will be also this emotional burden on the patients, on the relatives. Multiple relatives are involved. There is a thoughts and decision making which is involved. So a lot of things are happening to the same place. Suddenly the life has changed. So psychological intervention definitely makes a difference. We do involve emotional therapies. We do involve psychologists to talk to them. And when they understand what is the reality, what is going to happen, and the hopes over a period of time, that we give examples of the previous patients who have undergone this stress and they've recovered over a period of time. And once they see each single step of recovery, maybe it can be either movement in the leg or talking one word or two words. So these kind of small changes which happens in the patient, that will give one kind of satisfaction to the relatives. So these changes we have seen. Right. So till then, our duty, apart from treating them and doing all this physiotherapy, is also to give hopes to them,
Right.
and to make sure that they overcome that, right, to emotionally support them. That is very, very important.
Right. What future advances in neurosurgery and subsequent neuro rehabilitation interests you? You spoke briefly about neuroplasticity, involvement of artificial intelligence, and the brain-computer interface. Could you please elaborate a little bit more on that?
Yeah, so there are a lot of things which in the future is coming in the field of neuroplasticity, especially. So one of them is the virtual and augmented reality. So this will help the patients to improve their motor skills, the hand skills, and skills like speech, helped by these things. There are artificial intelligence like brain-computer interface, in which the patient's thought is converted into a skill. Like if the patient thinks, if his right hand is not moving, but if the patient thinks that he has to move his right hand, the machine will take over. That is because of the brain-computer interface, and it will try to move his hand.
Right.
This is called as brain-computer interface.
Right.
So these are the newer things which are coming up. So there is one more called as TMS, so which will help us to stimulate the nerves from the origin, and it will help us to connect through the tract, and it will help us to function or stimulate the motor function.
Right.
So if there is a deficit or weakness because of the acute strokes, the TMS can help to recover that function faster.
Right.
So a lot of robotics are also coming, semi-robots and automated robots. Though this will help us to work on each joints. The hand is a very critical with multiple joints involved, multiple skill level involved. So there are robots for hands, there are robots for legs, which will make us walk. So these are newer things which are coming, advances which are coming in robotics and the neuro rehabilitation, which is, I think, the future. Yeah.
Thank you. Great talking to you, Dr. Sachin.
Thank you.
What would be one advice that you would like to give to the public regarding brain and spine health?
Yes. So brain is a wonderful organ, and the spine also, but we have to understand that though there are many advances and new things coming up in the brain and spine, once the brain is damaged, the recovery of it is very slow. It takes a lot of time. So prevention is always better. So some things are not in our control, but some things like the road traffic accidents are under our control. So be a responsible citizen. Try to be very cautious on the road. Prevention is always better. So avoid road traffic accidents. That is one thing I can tell in terms of brain. The other things are not in your control. What is in our control is this is the one. The other thing is your healthy food habits. Avoid drinking, avoid smoking. Tobacco is known to be a risk factor for most of the cancers in the brain. So you have to avoid tobacco. And of course, your lifestyle. Try to maintain a normal fit weight according to your body mass index. The more weight you add on, your spine tends to get damaged. Use a proper posture. Give time to yourself, at least an hour a day. In terms of exercises, you can go to a gym with a trainer, or swimming, or running, cycling, something you have to do. And eat healthy food. Try to eat home food. Avoid outside food. This is all. And try to read books or whatever good things. Be positive. Think positive. Be positive. Stay positive. That will add on to your healthy lifestyle.
Thank you very much, Dr. Sachin.
Thank you, Dr.
This
Harish.
helps us a lot to understand.
Thank you.
And to take care. Wishing you all the best.
Thank you. I would like to thank Dr. Harish for his time and inviting me here, and Sukino for arranging this talk. I hope the people, whoever hears, will have a good information or insight through this. Thank you very much.
Thank you, Dr. Sachin.
Thank you.
Thank you. Bye.